Today, we're going to be talking about third degree ad block. This is the ECG that does not care if you are watching. The first thing I wanted to say about third degree ad block is that it is very dangerous. It's not like your first degree or your second degree where you may or may not do something. In a third degree ad block, you definitely have to act, and that's why it's important that you know what it is about. You've heard of slow heartbeats, but what if I told you that the atria and ventricles are on two completely different frequencies and your patient has no idea? So this is complete atrioventricular dissociation. And unless you know how to catch it, it will catch you out, basically. So here's what we'll cover, but trust me, this is not a list. We are going to cover, we're going to do a bit of introduction like I've done now. We're going to learn how to spot the blocks that medics routinely miss, from the causes to the ECG breakdowns, and how not to get distracted by irregular rhythm. Now, in third degree heart block, the electrical signal from the atria to the ventricle is completely gone. Nada, it's blocked, it's ghosted, and the atria fire, but the ventricles are like, oh, I don't know her. Who's she? Who's this person? So let's assume the ventricles are the men and the atria are the female. The ventricles are, sorry, I'm not in sync with her. I don't know who she is. So the ventricles kick in a sad, slow plan B, a junctional or ventricular escape rhythm, but it's often too slow, too late, or too unreliable. Now, this doesn't always look chaotic. Sometimes it looks very deceptively regular, and that's the trap. As you can see, this ECG, we're going to go into exactly why this is a third degree ad block. But as you can see in this ECG, there's no relationship between the P wave and the QRS wave. They're moving at different intervals amongst themselves. Sometimes you have a P wave, sometimes you don't have a QRS wave. But bear with me, we're going to break this down. Now, in complete atrioventricular block, this what we just mean is that, of course, as we've said, there is no communication between the atria and the ventricles. They are both doing their own thing, doing their own impulses, which is really dangerous, isn't it? Because here you have an increased risk of arrhythmias and of so many fatalities, including throwing a clot. So the atria and the ventricles, they stop talking to one another, and whenever this interruption occurs, you see that they beat independently, right? They're doing their own thing. It could be some form of ventricular tachycardia or interference. And so complete heart block is the pathological silence between chambers. So it's yes, there is no PL to QRS relationship. Sometimes you find out that the atrial rate is even more rapid than the ventricular rate. You have regular PP intervals. So the P to P intervals, as I was trying to get into here, I might have to annotate. So the P to P interval, this is your, let's assume this is your P, right? So from the P to P interval here is regular. The RR interval is regular, but the P wave just doesn't follow what the QRS is doing. And that's what we're trying to explain here. Now there's complete conduction of in the atrioventricular junction. So the rhythm has many enemies. Know that it could be as a result of post-surgical trauma, inferior myocardial infarction, cardiomyopathy, congenital issues, right? And but the biggest enemy is delay, really, because when a patient has 30 beats per second and you're still checking guidelines, they are checking out. So that's the biggest problem we have. And conversely, it can be congenital. I think that's what I wanted this slide to say. And conversely, acquired third degree heart block is a common complication of heart disease, particularly in older people. Now, complete heart block. I just wanted to say before we moved on as well that complete heart block after an inferior MI is so classic that it should come with a warning label. So you've resuscitated someone or they've done PCI and it was an inferior MI. What you would probably find in quite a number of these cases is an inferior is a complete heart block. So if you see inferior S elevation MI and bradycardia, please don't waste time. Pacing is not optional. Now, high-grade intraventricular block. This is a type of severe second-degree heart block, right? And with a very slow ventricular rate, but still some evidence of occasional atrioventricular conduction. So this term dissociation just means that I've said it again, I've said it before that there's independent atrial and ventricular activity, and it can be caused by other entities other than the heart block, complete heart block itself, right? So I think I think that it's important to let you know that complete ad block, to reiterate that it's not just another ECG find, it's a code red. So when you find a complete ad block, right, you're looking at a sudden cardiac death machine if you ignore it. If you need to continue monitoring, do your cardiac monitoring, do consider your backup pacing and have a plan fast because you don't want to many times, like I said, it can be deceptive and you think, oh, this is like a stable bradycardia, but you don't want that to lull you into comfort because these patients can really flatline fast. And what many medics forget is that they may look alert, they may be talking, but the floor is falling fast beneath their rhythm, and unless that pacemaker arrives fast, so will the patient go. So in terms of symptoms, um what we want to know is that they can have a wide range of symptoms, which can be life-threatening. They can also, like I said, be fully talking to you, but this heart block is regarded as a medical emergency. And atropine will not halt the patient with third-degree heart block unless they are unstable and cardiac pacing is delayed in order to administer atropine. So it's definitely a good idea to think of atropine. Now, in complete heart block, so in this case, what you have is the atrial rate is about 85 beats per minute. So if you can pick out the atria here, it's about it, and if you add a rhythm strip, that would really be helpful. But the atria is about 85 beats per minute. The ventricular rate is about 38, and none of the atrial impulses appear to be conducting. Now, please ignore this ECG. I'm not quite sure. This is the ECG that I wanted to bring on. But yes, we're going to confirm together now if this is indeed a complete heart block. So as you can see, what you have here is the P wave. This is a P wave here. This is a P wave here. This is a P wave here. I mean, one could argue that this is a P wave here, yes, and that's this. But of course, you have another one here. But basically, look out for the fact that there is no definite relationship between the P and the QRS. It's occurring, on its own differently. You cannot establish a relationship. In your first degree, you know that the PR is prolonged. In second degree, you know that you could have Mobit 1, Mobit 2. You could have gradual prolonging of the PR interval and then one QRS drop, or you could have the PR interval being the same throughout until the QRS. But yeah, you cannot establish that relationship. And it's really important to know. Um, I might be sending you a link or just linking you up with resources, especially if you send me a message to have classical complete ad block signs, because you need to start with the simple ECGs before you go to the more advanced ECGs, right? But one thing you need to know is that in many places where you have inferior MI, you could have a complete ad block, or you could have someone that has just come out of an MI, now presenting with a heart block, which is still an emergency. So in this slide, this is a bit more obvious. You can find that the atrial rate is about 60 beats per minute. So if you look at the atrial rate, it's about 60 beats per minute, but the ventricular rate is much slower at 27 beats per minute. And none of the atrial impulses appear to be conducted to the ventricles. So there's a slow ventricular escape rhythm. And, in this case, this is if you send this patient home, you're just not, it's not about negligence, it's quite dangerous because their ventricular rate is so slow, their atrial rate is beating much faster, there's complete dissociation. These people need to be paced. Now, in this ECG, what you have, so if you're not quite sure, these are your P waves. You have one hiding in this QRS complex, but these are definitely P waves. right? And if you count the P waves, if you look at the interval between them, there are about three boxes in between each P wave, right? And here you would find that it's about running about 100 beats per minute. But what do you find? This is a very clear-cut classical case of complete heart block. But as you will see, you would have complete heart block that does not have that in which the ECG still looks quite busy, and you're thinking, oh, is this really a hard complete ad block or not? Because I've told people in the past that when you see very bad bradycardia, before you think this is stable, look very much for complete ad block. But in some cases, it's a bit dodgy, and there's so much going on in the ECG, you already know something is wrong. Even before you think of a complete ad block, you can see the ST elevation in 2, 3, you can see it in AVF, you know something is definitely going on. There's an inferior MI here. It doesn't take too long to know that there's an MI here because of reciprocal changes, right? Even though you do not catch, even if you're not interested in whether there's a complete heart block here or not. But in cases like this, it's much more obvious. Then when you go to example 3, you can see that it's so bizarre. The P waves, you're seeing the P waves and they're occurring regularly, but the ventricular rates are just 15 beats per minute. And this patient needs urgent treatment with atropine, isoprenaline, and pacing. And pacing, right? In example 4, complete heart block with isorhythmic atrioventricular dissociation. And here, basically, this is even where the smart clinicians, where they mess up. And you're thinking, oh, this looks like a 2-to-1 block. Oh, but what you look at closely, if you're looking at the P waves, right? If you're looking at the P waves, is that they shift. The PR intervals vary. And so this is not the classical one you would see, but you find that this is what we call the isorhythmic dissociation. So this is not just math, it's a mixed pathology. It confirms that the atrial impulses are not being conducted onto the ventricles. So some of the P waves are superimposed under the QRS waves, like I did mention, but the ventricular rates remain regular. The apparent relationship between the P wave and the QRS wave is occurring merely by chance, and that's why it's called isorhythmic atrioventricular dissociation. Now, this is quite advanced, but it's if you call this a 2-to-1, block, I mean, a lot of people will see why you did so, but if you looked more closely, you find out that it's probably looking a bit more rhythmic because seems to be some apparent P wave relationship, but there isn't really. What you find is that some of the P waves is hiding under the QRS wave. Thank you very much. If this made you uncomfortable, good, right? If it made you uncomfortable, good. It just means you need to go and revise and understand. And I'm going to still do so many videos really talking about exactly how the heart works and how that translates into your electrocardiogram. But if you want more rhythm breakdowns like this, the kind that saves lives, not just pass exams, subscribe, share, and follow, or just DM me. DM me. I'm very active right now on Instagram. DM the code. I tend to get my DMs full, I should say. But if you want a faster response, send an email at info@jmdmededu.com, and I'm sure to quickly answer you that way. Otherwise, I look at my DMs quite every couple of days or so just to see what other messages I am missing. But thank you very much. Do take care of yourself and revise real ECGs. That's the only way you get better at it.